Well, it's very nice to meet you all. Thank you so much for welcoming me to Casper, Wyoming. It's my first time here and it's beautiful. So today we're going to chat about sleep and fatigue, okay? And if you have questions at any point, feel free to raise your hand and stop me, okay? So a quick overview. I want to describe the difference between fatigue and sleepiness because they are different. Um, keep talking. Oh, okay. We'll go over different causes of fatigue as well as sleepiness and different treatment options for that. And then we should have plenty of time to kind of wrap up and answer any questions that you have. So sleepiness is the tendency to want to fall asleep. So think about you're sitting on the couch watching a movie and you fall asleep. That's sleepiness. Fatigue is a little bit harder to describe because there's not necessarily a universal definition, but it's excessive tiredness that can be associated with mental or physical exertion. So other ways people describe it might be they just feel exhausted or like they have lack of energy, they're feeling drained. So, you can see the difference there between the two. So fatigue can have peripheral causes. So that means outside of the brain, for example, or the central nervous system. And that can be loss of muscle strength with repeated activity, or there can be central causes, and this is more just the state of feeling exhausted, and that can be both mental or physical. Parkinson's patients tend to have both. In some cases, that peripheral fatigue, that muscle fatigue, can get better with medication. Some causes of fatigue, and there are many, but some can be depression, effects of medication, not getting good quality sleep, dementia or memory impairment, anemia or blood loss, low blood pressure or even blood pressure that drops when you go from sitting to standing can cause fatigue, problems of the thyroid, and in some cases, just progression of Parkinson's disease itself. So when thinking about treating fatigue, there are different things you can do. So one is kind of managing your energy, so budgeting your energy throughout the day, and maybe planning activities for certain times when you know that you have a lot more energy. So for example, some patients tell me I feel my best first thing in the morning. So if that's true in your case, then maybe planning activities more in the morning when you know you're going to be feeling more energized. Power naps can also be a great resource, and we'll talk a little bit more about naps later. Exercise can be really good. It seems a little counterintuitive, but over time, doing regular exercise can actually help with fatigue and help with sleepiness as well. Keeping a stimulating environment, so lights on, windows open, choosing fun activities, not just being home alone with the lights off, for example. In some cases, we may need to review medications and remove ones that are causing fatigue or sleepiness. And in some cases, we'll talk about the use of medications such as stimulants, but the evidence for this is a little bit unclear, and there are potential risks of side effects with those. So usually we try to do all of that other stuff first. So sleep disorders are very common in Parkinson's disease. As many as 90% of Parkinson's disease patients will have some sleep disorder or disruption of sleep. And it's really important because it can affect memory and thinking. It can affect your energy levels, how alert you are, and it can also affect mood. And most of these are treatable, as you'll see when we talk about them. So effects of sleep deprivation or not getting enough sleep can really affect the whole body. So it can cause irritability, memory loss, cognitive impairment, or feeling like your thinking is slower, hallucinations. It can raise your risk for type 2 diabetes. It can make it so that your reaction times are longer than normal. It can raise your risk of heart disease. So as you can see, the effects of sleep deprivation really affect the entire body. So that's why it's pretty important to do our best to get good regular sleep. So one thing that's very common in Parkinson's disease is called REM sleep behavior disorder. So this is abnormal movements during sleep. and in particular during a stage of sleep called REM sleep. Normally during this time, your muscles are actually paralyzed in, for example, somebody who doesn't have Parkinson's. However, in Parkinson's, instead of the muscles being paralyzed, they may act out their dreams. So, they may be dreaming they're going to catch a baseball, and all of a sudden you see them reaching out like they're trying to catch a baseball. And this can potentially be dangerous to either the individual themselves or to their bed partner, because in some cases, people may fall out of bed leading to injuries, or, they may hit their bed partner leading to injuries. So this is very common. It's seen in somewhere between 25 to 50% of patients with Parkinson's, and it may precede the other symptoms of Parkinson's by several years. So thinking back, you may remember even before you had tremor or difficulty walking, maybe somebody, your bed partner, told you that you act out your dreams. And as many as 90% of people who have a REM sleep behavior disorder will later go on to develop Parkinson's. So this is useful for us when we're researching ways to try to modulate the effect of Parkinson's disease. Because one of the questions is, do we just need to catch people earlier when we're trying to develop disease-modifying therapies? So some symptoms, lots of movements, can be violent or defensive. So if you're having a fight in your dream, you may be punching the air while you're asleep. Yelling or talking or having conversations can happen as well. It's almost never sleepwalking, though. That's actually a non-REM behavior disorder. So that tends to occur during a different stage of sleep and is different from this. So treatment for REM sleep behavior disorder. So some of the first things that we do is talk about bed safety. So in some cases, we may discuss lowering the bed so it's closer to the ground, having padded side rails or padding on the floor so that in those instances, if you do fall out of bed, that at least you're lower to the ground so the risk of injury goes down. Moving away nightstands and furniture. So like in this picture, I would suggest moving that nightstand away from the bed. And the reason for that is, if you are acting out your dreams, you're not smacking your hand into the lamp, or you're not falling over and hitting your head on the bedside table. In some cases, maybe discussing sleeping in separate beds if it's disruptive to your bed partner. We do often use medication. The first one that we use is most often melatonin, and this can be bought over the counter. This is just one example. There's several brands. But this is a natural sleep promoting hormone, so it's very safe. There's minimal risk of side effects. So that's usually what we go with first. If that doesn't work and there's still concern about safety with acting out of dreams, the next one we'll often consider is called clonazepam, or the brand name is Klonopin. So this is an anti-seizure or an anti-anxiety medication, but it's usually not our first choice because we do have to watch for side effects, including drowsiness, falls, or affecting memory or thinking. Restless legs is also very common in Parkinson's disease. So this is an urge to move the legs or an unpleasant sensation in your legs. And it usually is worse during periods of rest or inactivity. And it's at least partially or completely relieved by moving, or walking, or stretching, as long as the activity continues. And it's usually worse in the evening, or sometimes it only occurs in the evening. This happens in about 15 to 30% of patients with Parkinson's. It can also be associated with low iron, kidney disease, neuropathy, as well as pregnancy. And most of the time, the diagnosis is made just by talking to me, describing your symptoms. But in some cases, a sleep study may be needed. So treatment of restless legs. So sometimes we take a look at the medications that you're taking. So for example, certain antidepressants that help with mood may make restless leg symptoms worse. So it's a conversation about risk versus benefit, seeing if maybe we need to stop that medication, or anecdotally, in some cases, moving that medication to the morning can help. Avoiding nicotine, caffeine, alcohol, because all of those things can make restless leg symptoms worse. Exercising or having a warm bath or stretching before bed can be helpful. Increasing iron in your diet, and there's a few examples of different foods. And a lot of times we'll do iron therapy, even if your iron levels come back, quote unquote, normal. And this is because the thought process is you need slightly higher blood levels of iron to get adequate iron to your central nervous system. So even if the lab doesn't flag it as low, when we're thinking about restless leg, there's a little bit different threshold that we think of. If none of those things work, we'll often talk about medications. The two most common are going to be gabapentin, and there's a couple brand names behind that, as well as pregabalin, or Lyrica is the brand name for that. This can lead to sleepiness, grogginess, so we want to monitor closely for that, and in some cases can cause swelling, especially in the legs. Sometimes we will use what are called dopamine agonists. I put a star there because the latest guidelines from the American Academy of Neurology are actually recommending against regular use of these for restless legs. And that is because of side effects, which include sleep attacks, so suddenly falling asleep, impulse control disorders. So an example of that would be somebody picking up gambling and excessively gambling away their finances. And one of the other things to watch for is something called augmentation. And what this is that over time, the symptoms start happening earlier in the evening, and you need higher and higher doses of those dopamine agonists. So for the most part, really try to avoid these if we can. In severe cases that aren't responding to other treatment options, we may talk about opioid medications such as tramadol, oxycodone, or methadone. But these come with side effects like constipation, nausea, fatigue, unsteadiness, and there is the potential risk for abuse with these medications. There is a newer device out that can be considered, but right now it's a little bit tricky to get. I think it's only available in a couple states. I know California is one of them, and you'd have to like fly out and get fitted for it. So periodic limb movements in sleep. So these are repeated limb movements. So it's often flexion of the foot and flexion of the knee and maybe at the hip. So kind of like this. They look the same. This can happen in healthy individuals as well. This often goes up with age, and it's associated with several different sleep disorders, but especially with restless leg syndrome. And sometimes when you're describing what's going on, it can be a little bit hard to tell which is which. So having your bed partner kind of take note of things can be helpful. To have what's called periodic limb movement disorder, you have to have over 15 of those periodic limb movements per hour, and they have to be causing you symptoms of sleep disturbance or daytime fatigue. So that's when it's not just the movements, but now we're classifying it as a disorder. And in a lot of cases, we'll treat with benzodiazepines or those dopamine agonist medications. Hypnic jerks or sleep starts. So this is a jerky movement that involves different parts of the body. You can kind of feel a shock or a falling into a void. This tends to happen as you're falling asleep. So, probably most of you have experienced this at some point where you're falling asleep and suddenly you jerk awake like that. This can be triggered by fatigue, stress, sleep deprivation, vigorous exercise, caffeine, and nicotine. Up to 70% of the adult population will have this. And most of the time, this really doesn't require treatment because it happens in so many individuals. So sleep apnea is not directly related to Parkinson's. So this is something separate, but it's something that's very common. So I wanted to take time to talk about it as well. So sleep apnea means that there's witnessed interruptions of breathing, or you're waking up in the night, or you're gasping or choking for air. And there's a cutoff number of greater than 5 of these events per hour. Oftentimes you'll have very short awakenings that you may not realize yourself, but those short awakenings can lead to a lot of daytime sleepiness or fatigue. And So if you have a lot of daytime sleepiness or fatigue and you have snoring, it's a good idea to just go ahead and get tested for sleep apnea because it's very common and it's very treatable. And again, this is just showing how many different things sleep apnea can affect. So it can lead to dementia and memory loss. It can increase your risk for stroke. Headaches, especially in the morning, are very common. It increases risk for diabetes, obesity, and heart attacks. So really, you want to, if you do have sleep apnea, you want to make sure you're treating it to lower your risk for all of these other things. So sleep apnea is it's diagnosed with a sleep study. So this is kind of what the setup looks like. So you'd have so this is if you did an in-lab sleep study. You would have sensors at the nose to measure the air. You may also have sensors on your face and your scalp to measure eye movements and brain activity. And you'll have a belt around you, and that's measuring the effort to breathe. And then you'll have a sensor on your finger that measures the amount of oxygen in your blood. There are also home sleep studies that would mostly include the band around your waist and you have a little oxygen cannula, like a nasal thing that you would wear, and the thing on your finger, but you wouldn't have the sensors on your head. And so sometimes that's kind of a good first step for screening, and it's a little bit easier because you don't have to go to a lab. But in some cases, the results may be not quite enough, and you may still need to go to a lab. So treatments for sleep apnea. So the most common one would be a CPAP machine, and that gives positive pressure to help keep the airways open. In some cases, oxygen, and in some cases, a device to pull the jaw forward to prevent it from the airway collapsing. Insomnia is very common in Parkinson's disease. So how this is technically defined is inability to fall asleep within 30 minutes or having long periods of being awake during the night or waking up too early in the morning. This is probably the most common sleep disorder in Parkinson's disease. So there's lots of causes of this. So going to bed too early, naps, I wanted to bring that up again because we talked about before that naps can be helpful to treat daytime fatigue. So the thing with naps is you want to find a happy medium. So you want to nap earlier in the day and you want to limit your naps to 20, 30 minutes at the most so that you don't cause yourself to not be able to sleep at night. Anxiety, depression, having an irregular schedule, restless legs, sleep apnea, all of those things that we talked about, certain medication side effects. So like I mentioned, in some cases, we may consider stimulant medications for daytime fatigue. But one of the side effects of that is that now you can't fall asleep at night. So having to wake up in the middle of the night is a common cause of insomnia. And in some cases, having worsening of your Parkinson's symptoms. So maybe your medication's wearing off, your tremor's a lot worse, you're having a lot of discomfort from your medications wearing off. That's another potential cause of insomnia. So sleep hygiene is really important. This is probably things that we've all heard, but it never hurts to hear it again. But regular exercise can be helpful. Some people find that exercise is really activating for them. So if you're one of those people, I would say try to do your exercise earlier in the day. Don't do it right before bed. Avoiding alcohol and caffeine, especially in the evening. Avoiding eating super late, minimizing napping. So again, doing it earlier in the day and limiting the amount of time that you're napping. Getting a regular bedtime routine. And this is one that's really important that I see a lot. So if you're laying in bed and you're sitting there and you can't fall asleep and it's been more than 15 minutes, I recommend you get out of bed and go somewhere else and do something else. And the reason for that is if you keep laying in bed, not sleeping, your brain starts to associate the bed with not sleep. And you want to do something calming. So examples would be reading or listening to a podcast. I'd stay away from being on your phone, tablets, screens, because that light can be very activating. And of course, you want to make sure the bedroom's comfortable, make sure it's not too hot, make sure it's not too cold, So treatment of insomnia. So one of the first things is called cognitive behavioral therapy for insomnia. So this is it's a type of therapy to help work on patterns of sleep and making sure, for example, you're not sitting there ruminating and having the same thoughts over and over. So that's one of the first things to recommend. If there's not somebody local that does it, I know there's even apps on phones that can guide you through it. Melatonin, we use that a lot. That's that sleep promoting hormone that I mentioned before. If it's because your Parkinson's symptoms are getting worse, then we may consider adding a longer acting version of carbidopa, levodopa, or the brand name of Sinemet for bedtime. And sometimes medications like Lunesta we may talk about, but that one you want to be careful because that can cause drowsiness and it can increase risk for falls. And usually that should be pretty short term. It shouldn't be a long-term solution. In some cases, we may consider antidepressants like trazodone or mirtazapine because they have a side effect of making people sleepy. So excessive daytime sleepiness, so being too sleepy during the day. So remember, good sleep is about quantity, quality, and timing. So you want to make sure you're getting all of those under control. If all of those are doing well, then maybe medication side effects. So dopamine agonists. So for example, pramipexole, ropinirole, those can cause a lot of daytime sleepiness or even those sleep attacks. Mental health issues. Anxiety and depression can often cause fatigue or sleepiness. And in some cases, you may need to consider seeing a sleep specialist to really dive even further into what's going on. So the treatment is in some cases similar to the daytime fatigue. So again, that strategic napping. So limiting yourself, so set an alarm, caffeine, but again, focusing on using that earlier in the day rather than late in the day. Sometimes we may consider stimulants. An example is modafinil or Provigil. This has about similar efficacy as caffeine and minimal side effects. Other stimulants like methylphenidate tend to avoid because there's risk of cardiac side effects with those. So I just want to take a little bit of time to give you a little bit of updates on some research that's going on at the University of Colorado and just kind of what's new in the sleep and Parkinson's world. So there's what's one thing that's being looked into is timed light therapy, so getting bright light delivered. And in small studies, this has shown to improve sleepiness, daily physical activity, and depression, but we need bigger studies. There's a light therapy study going on right now that they're looking at the effects of treating both motor and non-motor symptoms of Parkinson's disease. This is actually currently enrolling and it's fully remote. So if that was something you're interested in, it could be a little easier to participate, especially being up here in Wyoming. There's another study, it's called Excites PD. This is looking at exercise for treatment for sleep and cognition. Deep brain stimulation and the impacts on sleep. This study is not enrolling right now, to my knowledge, at the university, but they're looking at some preliminary results of how deep brain stimulation affects sleep and sleep architecture in Parkinson's. REM sleep behavior disorder versus trauma-associated sleep disorder. So what that means is people who have post-traumatic stress disorder often act out their dreams. And so this study is trying to sort out REM sleep behavior disorder versus the acting out of dreams related to PTSD. And I'm actually going to go to that flyer. So they do need volunteers. So this is going on at the University of Colorado as well. So if you're interested, there's one in-person study visit and then 7 days of wearing a sleep and motion monitor. So again, if you're somebody who's interested in research but can't make all the visits to go down to the university all the time, this could be a good option for you. So in summary, things we talked about, sleep and fatigue are different, but there's a lot of overlap. And sometimes differentiating the two can be a lot easier said than done. Most sleep problems are treatable. There are lots of very common sleep issues in Parkinson's, including REM sleep behavior disorder, restless leg, those periodic limb movements of sleep, insomnia, daytime sleepiness, and sleep apnea. If all of those things have been considered and aren't really, and you're still sleepy, basically, at that point, I would consider seeing a sleep specialist. Oops. Thank you. These are different photos of my pets sleeping, so that is appropriate for today's talk. So that's Luna, the cat, Buffy, the dog, and Amelia, the cat. So
that would have been a good one to start with.
Yeah. Well, I would have made everybody too relaxed and had to fall asleep. So, but yeah, as Christy mentioned, I've just finished up my fellowship. I will be starting at UC Health in Loveland, Colorado in September. There's a phone number if you were interested in seeing a movement disorder specialist that's at least a little closer to you. But yeah, now we have lots of time for questions. So yeah.
So on that sleep research, I assume you'd have to go to Anschutz, not to Loveland for that.
Yes, unless you're interested in the light therapy one, that one's completely remote. So that one you can do over Zoom visits. I think they mail the light box therapy to you, and then you have visits over Zoom.
So you said that a person has to go once and the rest can be virtual?
That one is for the sleep and PTSD, acting out of dreams specifically. Yeah. But if you call the same number, it's the same phone number for either one. So if you wanted to do that light therapy study, then you could call that number as well.
I'll send out the slides to everyone. If you are registered and your email address is there, you'll get the slides.
Oh, perfect. Awesome. No, thank you. Yeah.
What's the best way to determine too much medicine? That's what I feel like. He's over medicated. I talked to different doctors. I talked to the pharmacists. I don't feel like anybody really pays attention to how much they're getting, like 4 times a day. To me, it's like a lot of medicine.
Yeah, that's a good question and a common one. So in terms of how much, and I presume you're probably talking about carbidopa, levodopa, or Sinemet. So there's no maximum number per se. So I can't say like, oh, this times per day or this number is too much. When it is too much is when you start getting side effects, or when you're taking it so often during the day, it's just cumbersome to try to keep track of that. So side effects, so some common ones would be like dyskinesias or wiggly movements, like Michael J. Fox is a good example. But again, sometimes people have those wiggly dyskinesias and they don't bother them. So that doesn't necessarily mean that we need to reduce medication. But if they're very large, big, I would say, yeah, we probably need to reduce medication.
Well, I don't think it's just carbidopa, it's everything else.
Oh, okay.
They're giving you,
Yeah.
I just really am very concerned about that.
Gotcha.
I thought there's way too much going in on medication.
Yeah. And are you talking about also non-Parkinson's medications?
Yeah.
Gotcha.
So.
Yeah, so I know, and this may depend on your primary care provider, but if you have a really good primary care provider, sometimes you can make an appointment to purely just go through all your medications, and you can just bring all of them in the bottle and go through and say, hey, is there anything that I don't need? Can we just make sure nothing's interacting with another medication, and see if there's anything that we can come down on. So that would be what I recommend if you're kind of talking about all the medications.
Wouldn't it be better talking to your pharmacist?
Yeah. So the pharmacist can tell you general information about your medications, but they ultimately can't change the prescription. So it's not a bad idea to talk to them and take notes, and you can bring that back to your doctor. I know, and again, this is going to very much depend on where you're seeing a primary care provider, but I know some primary care offices have a pharmacist in their clinic, and so they may do the appointment together, but that very much so depends on the clinic setup.
Yeah, so would that be a situation where if she's not getting satisfaction from her primary care provider, she could see a movement disorder specialist? Like
Yeah, sure. Yeah. So times to see a movement disorder specialist. So I I think that if you have Parkinson's disease, at a minimum, you should at least be trying to see a neurologist. So a neurologist is somebody who's completed their residency in neurology, so that's 4 years of training. But that covers all of neurology. A movement disorder specialist is somebody who's done extra training that's focused on movement disorders. And in my case, it was an extra 2 years. And so, for a general neurologist, they see a large breadth of things, but for me, I really focus on Parkinson's, tremor, walking problems, among other things. And so I think that if you feel that your questions aren't being addressed, or you feel like you're not getting as much information as you'd like, then yeah, that's absolutely a good reason to try to see a movement disorder specialist. However, if your questions are about non-Parkinson's related medications, then that would be a reason to talk again to your primary care provider, or maybe get a new primary care provider if you feel like that relationship isn't there. Yeah.
The two drugs that you talked about, the clonazepam
Clonazepam.
and gabapentin.
Yep.
He's on both of those things, and you were saying that it can cause side effects. So what were those involved?
Yeah. So, and they're not bad drugs per se. We use them. I use gabapentin quite a bit. So in this talk, I talked about using it for restless legs. It's also used a lot for neuropathic pain. So side effects can be sleepiness, grogginess, some cases swelling. And there's a huge range in the dose of gabapentin. So even if you are having side effects, doesn't necessarily mean you need to stop it. Maybe just go down on the medication. The clonazepam, when I use it, the main indication would be for acting out of dreams, that especially if it's interfering with safety. And that one can also cause sleepiness or grogginess. And in some cases can impair balance. So for treatment of acting out of dreams, I tend to use a pretty low dose of that medication. And that's only if we've tried the other things. I usually start at 0.25 or 0.5, to be honest. Yeah. Everybody's different, but.
And there's also another drug that Doug Hornberger has talked about, and it replaces the carbidopa levodopa, and it's something you put on your body, and it's kind of like a patch.
Yeah, so there's a couple different things that he could be talking about. So in terms of carbidopa levodopa, so there's different formulations. So there's short acting or Cinemet immediate release. There's also controlled release. There's also long acting versions. Those are going to be Rytari and Crexont are the brand names for that. Those aren't patches though. In terms of a patch, he may be talking about like a rotigotine patch potentially, but there's a patch that's a dopamine agonist medication. And that comes with those same side effects of the sleep attacks, impulse control issues. And then there's a very new therapy that's out right now that is almost like an insulin pump, but it delivers carbidopa levodopa.
That's
Yeah.
the one.
Yep.
So is it basically no different than what he's taking orally? It's just
So it's phoslevodopa, phoscarbidopa, but essentially it works in the body the same way. But the difference is instead of taking a pill and then the levels of the medication kind of peak and come down, the thought is that you're getting a more consistent stream of that medication.
have you done anything like that? Or?
Yeah. So I've programmed a few pumps during my training, and there's some patients who really liked it, felt like it really evened things out during the day. Some patients didn't like it as much, felt like they did better on the oral medication. It does come with risk of skin infections or causing nodules of the skin. And it's fairly expensive and it's not covered by Medicare yet. So.
That was gonna be my next question. Have you heard if Medicare, when they're gonna pick that up?
No, I just keep hearing soon. So I don't know.
I keep hearing this summer,
Okay.
but
Yeah.
I don't know that that's happened yet.
Well,
Yeah.
you said the VA is covering it though?
The VA is covering it. Yes, that is true. Yeah. Is there a VA here?
Yeah.
Okay, gotcha.
And if you need me, I think I've spoken with Jerry about getting Brian from AbbVie to speak about that to the support group. I'm happy, if you bring that up with Jerry and let her know you'd like for him to come. I think he's taking a leave of absence right now from work, but he should be back soon. He's great to talk to. He can answer tons of questions.
I was gonna say, he actually presented Cheyenne.
Yeah, he'll come and present to the whole group.
Answers a lot of questions.
Yeah, he's very informative and really realistic about it.
Who does he represent?
He's from AbbVie. AbbVie is the company, the drug manufacturer that does the pump. And I don't know, I'm sure Steve wouldn't mind me telling, he started it, and so you're welcome to talk to Steve about it today. I might be telling you guys that. Would you mind?
Yeah, sure. That's fine.
Do you know, or maybe Sherry knows, whether we have any sleep therapists in the state?
That's a good question. I don't know.
It is so hard to find a clinician
Yeah.
in the state. If anyone knows of a sleep therapist, let me know and I'll put them on our list.
But, if you're at the point where you're seeing a sleep specialist, even if you did have to, I understand it's quite difficult to travel, but it wouldn't be quite like your primary care where you'd be going every, several months or something. It may be a once or twice consultation. So even if you had to travel a little farther, it, may still be something worth considering.
Do you recommend they go down to Anschutz for that? Is that the closest?
Right now I would, but I don't know the sleep people in Fort Collins yet or Cheyenne, so I need to learn that. Yeah.
This one, this is a frequent urination.
Mhm.
She gets up all night long. But of course, the question is she get up because she has to go to the bathroom, or she go to the bathroom because she wants to?
Yeah.
And there's no right answer to it, but that's very common with Parkinson's.
It is very common. Parkinson's, in addition to affecting, causing like tremors, slowness of movement, walking problems, it causes a whole lot of what we call non-motor symptoms, one of which is sleep problems. Another is issues with bowel and bladder. So like constipation or frequent urination. So that's very common in Parkinson's. There are medications that can be tried if that was something of interest. Other things can include
She's on Myrbetriq.
Myrbetriq. Yeah, that would be the one that or Gemtesa. There's other medications that can be used, but they carry the risk of worsening thinking and memory problems. So those are the two I tend to try to focus on. But other things that you can do is, so you want to make sure with Parkinson's you're drinking plenty of water because it's really easy to get dehydrated or get low blood pressure. But alternatively, maybe cutting off fluids for an hour or two before bedtime just to try to prevent as frequent of urination at night.
What was the second drug?
Gemtesa, it works similarly to Myrbetriq.
Just a point of factor, I went and saw a urogynecologist, I had surgery, blah, blah, blah. I had the urodiagnostic study, whatever it's called. And it comes out looking like an EKG, and you get all these lines, and he goes, you see all those little wiggles, mine were like this. And he goes, his mom had Parkinson's, and he says, it's not unusual, it's spastic bladder. Now, he said that that's not unusual. Parkinson's.
Like your bladder's tremoring?
Yeah, seriously, no joke. I mean,
Yeah,
mine
believe it.
started after I had a hysterectomy. It hurt so bad. I was already on Myrbetriq and went 25 to 50. And I cried for a week because I had to go to the bathroom all the time. And hey, bottom line, there's also an electric. My husband jumped. The doctor explained it that there's a nerve that goes into the bladder through the sacral. And he says if they stimulate that, sometimes that will help slow down that tremor, or whatever you want to call it, in your bladder, over a spastic bladder kind of thing. And he said that there's, I can't remember, I want to say it's called BBM, or anyway, I don't think I have the stuff in my car.
I want to say it's either tibial or perineal nerve stimulation.
Hey,
I don't remember exactly. Yeah.
You can try it. He said you can actually try it for 3 or 4 days without actually fully implanting to see if it helps, so that you're not paying for something that might not work. It's just a thought.
Yeah, so that's a really good point. So in my realm, if frequent urination is an issue, I'll usually try one of those two medications that I mentioned. But if that doesn't work, probably at that point, I would be talking about seeing a specialist like a urologist to see what other therapies they can offer because they do have devices. They also, I think sometimes they'll even do Botox into the bladder. So they have a whole lot of other things. Yeah.
But
Yep.
John Crane, he's a urogynecologist, he's in Loveland, because there was another guy. that
Good to
was in
know.
Denver. I live in Cheyenne, and I realized Casper's even 170 miles, that's the closest I knew of, I mean, they didn't say, well, here's one in Wyoming, they just said, well, here's two of them. The closest was Loveland.
Gotcha.
Very nice, this guy,
What was his name again?
Yeah, write that down.
John Crane,
John Crane.
Crane, like a bird, Crane. Yeah, anyway, just, I get it, I had.
That's our list. That's such great knowledge. Thank you for sharing.
Yeah, thank you.
Because of personal experience.
Yeah.
So, what do you know about the funding for these various studies? I know that, the APGA and the Parkinson's Foundation and Michael Fox just issued a statement saying, please don't take away research funding from the
Yeah.
National Institutes of Health. Is this federally funded?
I'm not sure where they're getting the funding for these studies specifically. And I can speak a little bit to the University of Colorado. What I recall hearing is that they weren't going to stop any studies that were already approved or ongoing. It was more about limiting studies that get approval later on and kind of limiting what those studies focus on. And I know the University of Colorado has been taking steps to try to keep greater reserves for research. So for example, they've limited travel funds for like conferences and things like that because they're trying to keep extra additional money in reserve for research. So it's scary times, but yeah, we're doing our best. Yeah. Did you have a question or? Yep. Okay.
Maybe you want to talk to everyone about an outcome too, because it's another newer therapy.
Oh, the second
that
subcutaneous.
morphine.
Yeah. So that one I have less experience with because it was pretty recent, like even more recent than the AbbVie pump. But there is a second pump that delivers a dopamine agonist, apomorphine, continuously. So there's now two options for pumps. I don't know as much about their coverage. I haven't programmed one of those myself. They did have a representative come in and show us the device and everything, but I don't know if anyone's been programmed with it yet at the University of Colorado. I would have to check back in. I am taking a little bit of time off after fellowship, but when I left, nobody had done it yet. So
A couple of patients use it just as another option. And the nice thing about an APCO versus Violet is that an APCO, an RN, no matter where you live, in Wyoming, Montana, no matter where, an RN comes from the closest place that they live to, they come to your home. And they actually titrate this for you, so you don't actually have to go to your clinician's office to do it, and they will titrate it. They start with about 0.5 ml. It's on 16 hours a day, and it's not like that. Maybe some of you have heard about the dual pump, which was actually a tube that needed to be surgically inserted and it was fed down to the jejunum. But this one is just like a little patch that goes right underneath your skin. And the nurses there should come out and visit you 3 times, no matter where you live, 3 times a year to get you going on it. So it's just it's just kind of cool that we have some newer therapies now for people. We have newer options, right? And I think the whole issue is trying to diminish off in people with Parkinson's, the roller coaster of oral medication. You're on, you're off, because the gut is so affected by your Parkinson's that you get these unpredictable offs and unpredictable ons. And so I think a lot of the companies are looking at, like GPS, how can we give patients more good on time to improve the quality of their lives? So these are just really good, wonderful things, along with, of course, deep brain stimulation, which is phenomenal. But they are really good therapies, and certainly don't have a cure for Parkinson's yet, but we do have some new therapies, which is great.
So the deep brain stimulation, does it help stay asleep?
So it is not a indication to get deep brain stimulation, but there is evidence that it does help improve sleep quality in Parkinson's patients. There's a lot of research looking into that currently. But one thought is it helps smooth out those motor fluctuations, which can help sleep. We're also looking in to see if it actually affects sleep architecture itself. But it wouldn't be a reason that I would say to get the brain surgery, but it's kind of an added bonus that seems like it might be helping with sleep.
Can you speak about who would be a good candidate for deep brain stimulation
yeah.
surgery?
So when we're talking about deep brain stimulation surgery, so has everybody heard of that before? Okay, so I'll just to make sure everybody's on the same page. So it's a surgery where electrodes are implanted into the brain and connected by a wire to a battery in the chest. It's essentially a simple way to think of it is almost like a pacemaker for the brain. And reasons that we do that would be for somebody who has a lot of motor fluctuations. So they take their medication, they're on, they get a lot of wiggly dyskinesias, and then it wears off really quick. And now they're super off, having lots of tremor, slowness, stiffness, things like that. And we tend to use it for somebody who, we've done everything we can with medications, but we can't get it under control. And for the most part, deep brain stimulation helps the Parkinson's motor symptoms, so that tremor, stiffness, and slowness. And for the stiffness and slowness, it helps about as much as medication does, but it helps keep it smoother. For tremor, sometimes it can help a little bit even more than what the medication does. So those are reasons that we would start talking about deep brain stimulation. Reasons to not get it would be, if somebody has dementia, that's a reason that they would be excluded from getting deep brain stimulation because there is risk of making cognitive symptoms worse with it. And then, like I said, it tends to help with sleep, but that's not a reason that I would say, let's get the brain surgery. Any other questions about DBS or sleep or anything?
Yeah, you mentioned with the drugs for sleep around the agonists. You indicate that the agonists were worse for sleep than just Cinemet, or
Yeah, no, that's a good question. So in terms of Parkinson's medications to treat sleep, so the time that I would use it is so after, say after like 4 hours, you wake up because your Cinemet's worn off. So I might say, let's try a long acting version to help try to get you through the night so it's not wearing off in the middle of the night. The dopamine agonists, so like pramipexole or ropenetrol are examples of that. I personally would not use that to treat sleep. The point about those is that it can actually cause a lot of sleepiness or even sleep attacks where you're suddenly falling asleep. Yeah. So I tend not to use those medications because of all their risks for side effects. But
What do you prescribe to children?
I really don't often. So I can tell you why they used to be prescribed a lot more and why they're not as much anymore. So it used to be thought that we should delay starting carbidopa, levodopa, or Cinemet because there was concern that it would cause those wiggly dyskinesias sooner if you started it sooner. But there was a big study that showed basically it's not how it's related to how long you've had Parkinson's and how long you've been on the medications. So to get the wiggly dyskinesias, it's a side effect of the medication that only happens in people with Parkinson's. So if somebody had been trained, and they weren't updated, they may say, well, I was taught that I should delay Cinemet as much as possible. So therefore I'll do a dopamine agonist. So that's one reason that you may see that used. So it's rare that I use it, but reasons that I may use it would be if somebody really can't tolerate carbidopa, levodopa, or Cinemet because they're very sensitive and they get a lot of the wiggly dyskinesias, because there is a slight lower risk of that with the dopamine agonist. But again, usually pretty cautious about that and I'd probably try other formulations of carbidopa, levodopa first, or adding additional medications like amantadine, or start talking about like deep brain stimulation. So it's pretty rare.
Speak to some of the the scarier maybe or more concerning side effects of the agonist. I'm not sure that everyone knows about that one.
Gotcha, yeah. So the sleep attacks, like we talked about, so that can be really dangerous, especially if you're driving. Impulse control disorders can happen with the dopamine agonist. So, for example, excessive hypersexuality. So I've heard stories of people suddenly cheating on their spouses when that's not in their personality or anything that they would have done before. Excessive gambling or excessive shopping. So suddenly they've drained all their savings because they just can't stop gambling, and that's really not normal for them.
Or just go and buy stuff.
Or going out and buying stuff, yeah.
No, laugh, it's more than just you, I want to go out and buy stuff.
Yeah, it's like I'm buying so much stuff now I can't pay my bills type of thing. So it's rare, but it's obviously it can be pretty serious. So if anybody is on a dopamine agonist, it's something that I try to screen for every visit.
Is there a time frame that they say you can only take it for so long, or do you just watch the risky behavior?
Yeah.
You just keep an eye on it, or is it like you can only do it for 10 years?
There's not a time limit. It's something that I tend to watch for. And then something as Parkinson's progresses is maybe the motor symptoms like the tremors start to become less important. And now the memory and dementia and hallucinations start to become more important. And especially dopamine agonists can increase risk for hallucinations. So that would be, there's not a number of years, but that's another reason that I might say, okay, we need to come off of those dopamine agonists because I'm worried it's making you hallucinate.
And the original thing on dopamine agonist, if I remember correctly, correct me if I'm wrong, is an agonist is like, it's like tries to trick your body into thinking it's dopamine. Is that something like that?
Yeah, that's a,
I mean,
I like
it's
that.
a fall and fake, your body thinks it's dopamine instead of actually being dopamine. I mean, that's what I read on. I mean, like,
Yeah,
I just,
yep.
yeah, haven't heard very many people talk about it anymore. I mean,
Yeah.
I started reading up on it when I first got my diagnosis, and I was like, okay.
Yeah, essentially it works on the same receptor as dopamine. So instead of the dopamine binding, the dopamine agonist binds to that receptor. Yeah. Any other questions?
Now's your chance.
Yeah. Yeah.
Quick question. Entacapone.
Mhm.
What's your thoughts on it along with the carbidopa?
Yeah, so it's fine. So that's a medication. So entacapone it's called a COMT inhibitor, so it helps prevent the breakdown of the levodopa. So the thought process is that it should make it last a little bit longer. So in theory, you should get about a half hour extra time with it. I've heard mixed reviews from patients, how much they feel like it really does or doesn't, but I think it's certainly worth a try. And that reminds me, so there's another class of medications, they're called MAO-B inhibitors, and they also work to try to keep dopamine around longer. Two examples are selegiline and rasagiline. Both have some evidence they can help with fatigue, but selegiline in particular gets broken down into amphetamines. And so with that thought process, sometimes I'll add that medication on with the idea of hopefully it'll help a little bit with fatigue.
Why does, you mentioned it, I think it's an antiviral amantadine.
Mhm.
Where does that fit in?
That's a good question. So the way that I use amantadine primarily is to treat those dyskinesias. Again, you may see some older schools of thought of, well, let's do everything but carbidopa, levodopa. So some people might get started on that earlier on, but for the most part, that's the main time I use it is for treating dyskinesias.
Do you find that it helps with fatigue at all?
So it's
Is it off-label?
So it's interesting. So actually in my neurology residency, we would use amantadine for post-stroke fatigue. So I came here and asked, well, do we use it for Parkinson's? And the program director, Trevor Hawkins, was like, it doesn't seem to work as well for fatigue related to Parkinson's and something to do with the pathophysiology of Parkinson's being different than post-stroke fatigue. So I don't often use it for that. I think, especially if you have dyskinesias, it's worth considering, but You're fine.
Sorry.
So maybe it might help-ish.
Maybe, I don't think there's a lot of evidence for it. I think the evidence is more for like post-stroke related fatigue.
I was gonna say, I actually had my first neurologist put me on amantadine when I was on Xadrez at some point and didn't feel like I was getting anything from it, and I no longer on it, so then I thought I'd asked again.
Yeah.
Did I miss something?
Yeah. So it's very rare that I would do one of those medications before starting carbidopa levodopa. But if somebody said, hey, I really want to use a medication that's the least likely to give side effects, but maybe it won't help as much, then we can talk about those options. But for the average patient with Parkinson's that comes in, if I'm going to start a medication, it's probably going to be carbidopa levodopa.
When do you think folks should talk with their providers about sleepiness and fatigue? Like, when should they open that conversation, and what are some of the first topics they should bring up?
Yeah, so I think anytime that you notice it is a good time to start bringing it up, because there's different things like easy low-level things would be checking thyroid function, making sure your B12 isn't low, because those are some common things that can cause fatigue or sleepiness, getting screened for sleep apnea. So if it's affecting your life, it's worth bringing up and talking about to see if there's anything else we need to screen for. And it doesn't have to be with your movement disorder specialist. You can start with your primary care, and because they treat sleep apnea all the time too, probably more than I do. So, yeah. But if it's not sleep apnea and seems related to Parkinson's, then it might be better to talk to your neurologist about it.
So I have a question about just general care with movement disorders specialists. Since everyone is so far away from movement disorder specialists, and maybe they go once a year or so, and maybe see their neurologist in town for other subsequent appointments, what do you recommend for care? Do you recommend coming with 3 questions, or what is your recommendation for seeing you less often? Or a movement disorder specialist less often?
Yeah, that's a great question. I would recommend coming in with a list of your top 2 or 3 things that you want to talk about that are most important. We have in our note template, there's always a review of systems where if we have time, I try to ask every potential symptom that's related to Parkinson's. But as you can imagine, a lot of times there's not enough time in an appointment. So if I know right off the bat what your biggest concerns are, that helps save a lot of time so we can start troubleshooting right away. And having questions ready is always really helpful. It just helps kind of streamline it and save time for you.
How helpful is it for patients to come with a sleep tracker, and how long do you recommend them tracking their symptoms?
Yeah, it's definitely helpful. So I have mixed feelings about it. And the reason for that is because I get some patients who overdo it and they write down their symptoms every 10 minutes of every day. And it's this is too much information. And the thing about Parkinson's is you're always going to have some fluctuations. And I see it a lot in DBS patients, because we tell them okay, watch closely to your symptoms tracking, come back and talk to me. So what I've started to try to tell people, and I'll see how this works, is I want to know about patterns. I want to know about things that keep happening. Because if something happens once in a blue moon, probably don't need to worry about it. But if it's happening every day at a particular time of day, or, it's always an hour before my medication, that's the kind of stuff that's really helpful for me to know, is those patterns. Because I also don't want you to go home and be thinking about your Parkinson's every second of every day, tracking every tiny symptom. So
you don't have to focus on that.
Exactly.
Separating on everything.
Yeah, my goal is to, as much as I can, make you think about Parkinson's less, not more. So
Are you familiar at all with Stripe PD? You use that all that app?
I did not, no.
Stripe. So it's an app through Loon, and basically what it is they take phone, and then you have to have an Apple Watch, and it passively will collect your symptoms, like how much dyskinesia, how was your sleep, how much tremor are you having. You can set it up. They have another part of it that's called Guardian, where you actually have a coach that helps you set it up in your phone. And then when you go see your person taking care of you, it will literally say, oh, it looks like the dyskinesia was really happening at like 2 o'clock every day, or the sleep has been interrupted. This person's only getting like 4 hours of sleep a night. So anyway, talking about symptom tracking is very cool. It's more like a contemporary way that the people taking care of you can actually get
More objective.
yes, and a snapshot, not just of that day for 3 questions, but obviously what's happened in the last 3 months or 6 months. And then the coach will actually call you. The Stride PD is actually free. I mean, that's just an app. You can, it's right here, you can take one of these flyers. The Guardian is actually $600 a year or something like that. But what the Guardian does is they call you before you have your appointment. And they analyze the information and they're like, look, this is what I want you to talk to them about. This is what I see. This is the objective data. So you're not having to write down all those little symptom trackers and things. So it's really great. They actually did a huge study at Kaiser, about 180 people with Parkinson's, of course. And they found that 3 things, like the falls decreased by 40%, medication adherence improved by 60%, and exercise improved by 80%. Why? Because they were accountable. They had to not just, the app can pick up, are you walking like this? Or are you walking like this? You know, I mean, so it can actually pick up how much and what kind of exercise you're doing.